Hi, everyone. Good morning. Welcome to our first Learning Collaborative activity. We're going to get started in a minute, but while we wait for maybe just another minute for folks to join, feel free to add your name, your pronouns, your location, the organization or the health center that you work at in the chat so we can get to know everyone who's here joining us. We'll just wait another few seconds and add your name and your pronouns and your organization to the chat. Nice to see everyone. Great. Well, I'll go ahead and get started. My name is Elena Josue. I work at Health Partners on IPV and Exploitation. We're a project of Futures Without Violence, a national nonprofit based here in San Francisco. Today is the first of a series of 4 learning collaboratives we are co-hosting with our partners at the National Center for Medical Legal Partnership, who will share a little bit more. Bethany, my co-host, is here. And, I'll have Bethany introduce herself in a minute. This is a peer learning collaborative. We're going to share a lot of information about medical legal partnerships, informal partnerships, collaboration, to address the needs of survivors experiencing intimate partner violence and exploitation. We also hope to hear a lot from you all throughout the conversation and give all of us a chance to learn from each other, since we know that you all are doing really impactful, important work and grappling, problem solving through challenges that perhaps others are sharing too. So with that, go on to the next slide. So I wanted to acknowledge our funder, the Health Resources and Services Information. Both Health Partners on IPV and Exploitation and the National Center for Medical Legal Partnerships are supported by HRSA to do this work and to present this activity, and we're really grateful for their support. Next slide. Like I mentioned before, I work at Health Partners on IPV and Exploitation, a project of Futures Without Violence. We are funded by HRSA, the Bureau of Primary Health Care, to do this work with community health centers and support those who are at risk of experiencing and surviving intimate partner violence, human trafficking, or exploitation, and also to talk about prevention, which I hope we'll get a chance to do throughout this learning collaborative as well. We have a whole bunch of resources on our website, so really would encourage y'all at a different point in time to check out our website, healthpartnersipve.org, to check out different webinars, activities, other learning collaborative toolkits, evaluation resources, all kinds of things on our site. And Bethany, you want to introduce yourself in the National Medical Legal Partnership?
Sure, I'll be really brief. So thanks for joining us, everyone. It's nice to see the group that made it to today's session 1 of our learning collaborative. I'm Bethany Hamilton, co-director of the National Center for Medical Legal Partnership. We are very proud and happy to partner with Futures Without Violence, and as they are known, Health Partners. I'm going to mess this up. So I'm going straight to the slide to say it right. Health Partners on IPV and Exploitation, as they were recently renamed. But we've been working with them for years to really help bridge together not just the medical and the legal, also through events like this, the DV advocacy programs, the CHWs, and others to help address those social needs with legal underpinnings in an integrated way. But I do want to just put a little footnote here to say that whether or not you have an MLP and you're joining us, we will be discussing how you can just do informal partnerships. They are still bona fide partnerships, but not necessarily a formal MLP, and get this work done. So thank you, Elena. With that, I'll pass it back to you.
So we do start so many of our trainings with this particular note. Because domestic and sexual violence and human trafficking are so prevalent, we always assume that there are survivors among us, and we like to remind our audience to be aware of your own reactions and take care of yourself first. It's okay to step away from the Zoom if you need to. And then because of the topic, we also ask our audience members to respect patient and client confidentiality in our conversations. Next slide. For today, these are our learning objectives for our entire Learning Collaborative series of 4. We're going to be talking about building and identifying strategies to build partnerships between civil legal services providers and community health centers to address the health and legal needs of survivors of IPV and exploitation. We're going to talk about growing and sustaining those collaborative responses, and thinking about the ways those collaborative responses can also be addressing prevention. And then we're going to give you all a whole bunch of tools that we hope as you continue this work or grow your work, think about sustaining this work, think about evaluating your work, that these tools might help you as you continue to formalize these partnerships and develop things like protocols for responding to domestic violence and building prevention strategies with your community partners. So today we'll be talking about, we'll give a little bit of an introduction. We'll share with you some tools that our programs have created and where to find them. At our next session, we'll have one of our guest speakers come, Pat Medage from Colorado Legal Services, who's going to talk a lot about their experience in developing informal partnerships and the ways in which healthcare providers have really helped their legal services cases and programs and provided training to them. On session 3, we'll be hearing from the Executive Director of Alaska Legal Services, Nicole Nelson, who's going to talk really about scaling and sustaining formal medical legal partnerships in Alaska and the work that they're doing to use medical legal partnerships as a way to address the justice gap as well. And then in session 4, we'll be talking with Indiana Legal Services about partnering to address the health and legal needs of older adult survivors of abuse and exploitation, and they'll share a little bit about their model and some of the innovations that they're implementing in Indiana. So like I mentioned, my name's Elena. I work at Futures Without Violence, and I'm joined by Bethany. I'm also joined by Dr. Kim Chang, who's a family physician at Asian Health Services. Hi, Kim. Kim will also be helping us through this conversation and can share a little bit more about herself later on in the presentation. Or you can also look up Kim on our website too. She's a consultant that supports our program here at Futures. You can go to the next one. Okay, so in the audience today, you might have seen in the chat that we have folks here from community health centers, we have folks here from domestic violence advocacy programs, we have folks here from civil legal services programs. You know, through this learning collaborative, we're really hoping to explore with all of you the opportunities for collaboration that exist between these 3 critical community services. We know that collaboration and partnership happens already, right? It happens by necessity. It happens when a need arises in your work and you're looking to find a community partner to help support someone with a specific need. We hope that we can start thinking about what does building and formalizing and growing these collaborations look like? What are some tools that can help you all think through questions like how to measure the impact of those collaborations, or what should the goals be of those collaborations? How can we use these collaborations to leverage some of the challenges that we're facing in our organizations or in our practice? In the chat, we're going to also paste a link to an article that was written by Dr. Kim Chang and one of our colleagues here, Anna Mariavi at Futures, and with Hamida Yousafzai about medical legal collaboration and community partnerships to address human trafficking. We encourage you all to check it out. And then throughout this session and throughout this learning collaborative, we really hope to hear from you all too about some of the things that you all are encountering or innovations that you have tried in your work, in the hope that it can help all of us continue to learn about how we can work together. Just a note on domestic violence advocacy programs. We're going to talk a little bit about health centers and civil legal services programs later on. Domestic violence programs and sexual assault programs have vast experience working with survivors of violence to assist them and identify ways to increase personal safety while also assessing their risk, crisis safety planning, housing, sometimes legal advocacy, support groups, counseling, children's services, employment support. These are just some of the different services that you might encounter at a local domestic violence program. So while we're talking about collaborations between health centers and civil legal services programs, we also want to be thinking about what are the ways in which the domestic violence advocacy programs in your community can also be linked into these partnerships and serve as a way to support both staff at these organizations and also your client and community patients and clients. You can go to the next slide. So at Futures, we had this quote for a long time, and I don't remember exactly who wrote it, but here at Futures, it's something that we share a lot, that success for us is measured by our efforts to reduce isolation and improve options for safety. I always really like to start with this quote because it kind of puts into perspective, answers the question of why we're developing the resources that we are, why we're doing learning collaboratives like this. We have this goal of trying to build, resources and materials that can help programs reduce isolation and improve options for safety. I also see that as a goal perhaps of many medical legal partnerships and collaborations as well. So I just wanted to share that with you and then start our conversation today with a question. In your work, whether it's a formal partnership that you have with the health center or a legal services program, or just a relationship that you might have with a domestic violence program in your community, what are some of the ways that you all are thinking about what success looks like in those partnerships? What would be something that would indicate that the partnership has been successful? Is it, and feel free to put your answer in the chat, or you can raise your hand and answer all together, but would it be, number of cases served? Would it be, some sort of specific systemic issue that you are working on together? What would be some of the ways that you might think about what success looks like in your partnerships? I see Callie wrote, addressing the legal needs that create barriers to getting and staying safe. So yeah, perhaps like just really specifically increasing the number of people that have access to free, low-cost legal services to address their needs related to survivorship. Anything else? Yeah, just like number of and breadth of services related to someone's experience of being a survivor, establishing meaningful options to offer survivors. So being able, I think we all know, right, that you can refer someone to a certain organization in your community, but sometimes the quality of that referral is also based on the quality of our relationship with that organization. How can we sort of facilitate that referral? And so perhaps a meaningful relationship with a community partner also helps to give survivors more options too for where they can go for help. You can go to the next slide. Thanks, everyone. Go to the next one. So I just wanted to share really quick that there are many, based on the research, many long-lasting health consequences for intimate partner violence and human trafficking. in addition to the immediate injuries that folks might think of, and that these health consequences persist and can persist even after an abusive relationship or trafficking situation has ended. And we share this slide because it is part of the reason why we think that thinking about partnerships proactively is so important, especially with our healthcare partner, between our healthcare partners and our legal services partners. There was a recent study done by the survey done by the National Domestic Violence Hotline about the intersections between domestic violence and primary health care. And some of the things that they found in that survey were about half of folks surveyed reported that their partner controlled or restricted access to their health care. And almost half said that the abuse intensified during COVID, something that I know many of you know. And 42% said that they do talk to their healthcare provider privately, which makes sense because we know that healthcare, those conversations with your healthcare provider might be one of the only spaces where you are alone with an organization that might be able to provide some support. You can go to the next slide. So then why, I think that slide sort of answers some of these questions about why are we building these partnerships, but these are just some of the things that I think come to mind for me when I think about this work. One is, something that a lot of you mentioned in the chat, or trying to improve outcomes for survivors, especially keeping in mind all of the potential health impacts that we know may exist from experiences of intimate partner violence and exploitation. And also thinking about the long-term outcomes for survivors as well. Prevention, right? We're thinking about preventing both future forms of violence, but also prevention, from a more systemic lens as well. Leveraging resources, something that we've been talking about a lot is just that how much so many programs right now are experiencing turnover, are trying to think about sustainability, are trying to think about options, different or diverse options for funding this type of work. Is there an opportunity in your partnership to address or solve some of those questions that you might have in your organization? And we can talk about that a little bit more as well. Supporting staff wellness. This is something that has come up in some of our other webinars and trainings as well, and we can share information that we have on our site. But domestic violence programs especially are often really great resources for thinking through training for your staff around trauma or vicarious trauma as well. Addressing complexity that exists in these experiences of domestic violence and human trafficking, and then finally, thinking through how can these partnerships expand prevention strategies as well, and how do we measure the impact of those prevention strategies? The next slide. At Futures, we've done a lot of work building this model of domestic violence partners partnering with community health centers partnering, and we're hoping that some of that work will also help inform this conversation of, okay, so then what does it look like to also include a civil legal services partner in that model? We'll share a bunch of resources, you can go to the next slide, related to that model, but some of the benefits that we've seen from those types of models we've seen certainly during COVID, which I'm sure you all as well probably have many examples of the ways in which DV programs and health centers have partnered during COVID around health enrollment, or establishing primary care providers for folks, COVID testings and vaccinations, mask distribution, developing new protocols for DV programs and shelters, and supporting the healthcare staff as well, and patients who are experiencing domestic violence. You can go to the next slide. And so many of these resources that we've developed related to developing these kind of partnerships, such as sample MOUs that might be useful, handouts on thinking through some of these questions about why or what are our goals in our partnership, you can find at this website that's up here, and that I believe Camila will also add to the chat. And hopefully they're useful to you as you're thinking about how do we formalize some of the partnerships that we have. Kim, do you want to speak for a second about this about the protocol as well that you all have been thinking through?
Sure. One of the primary objectives for the health partners on IPV and exploitation is to really support the community health centers across the country and every state, territory, and District of Columbia in providing care for people who are at risk of or affected by intimate partner violence and exploitation. And part of that is really making sure that in the health centers there are operational protocols available so that staff don't have to struggle with like, oh my gosh, what do I do now? I have a patient, I'm seeing a patient right now who's at risk. This doesn't happen every day. I don't remember what I'm supposed to do, etc. Who do I call? What are partners? What are my legal obligations? And so we created a protocol, a template, which has a lot of pieces in it around privacy, safety, confidentiality, reporting, the CUES universal education approach, which we'll go over a little bit later in this session, working with partners, domestic violence advocacy programs, and medical legal partnerships to get the resources that we need and the support that we need for our patients. We also talk about UDS, which is Uniform Data System Reporting, which health centers are required to do by the Health Resources and Services Administration, and also some of the electronic health records issues around that. So it's a really useful tool and template for your health centers or your health center partners if you're a DD program or an MLP or a civil legal services here on the call. We encourage you to download it, adapt it to your system, share it around, and let us know if it's helpful or give us any feedback. I think I'll just stop there, Elena. Thanks.
Sounds good. Thanks, Kim. So like I mentioned before, I think one of the other things that we're hoping to think through with you all is the ways in which medical legal partnerships utilize strategies that address preventing intimate partner violence and exploitation as well. I started my career as a civil legal services provider, and since coming to Futures and learning from healthcare providers and folks in public health, I think I've understood so much better about what prevention means, and certainly how to rethink some of the work that we do from this perspective of prevention, and how can that help prioritize our work, or answer this question of why we're doing certain things and partnering with certain folks differently. So I offer this here just in case it's helpful, and I'm sure many of you have also seen it, but I think it's a helpful framework for thinking about the different ways in which our work might lead to prevention. So we think about tertiary prevention to address and reduce the long-term consequences of violence, secondary prevention to intervene in order to reduce the escalation of violence and mitigate immediate consequences, and primary prevention, which is to prevent violence from ever happening. And you might think about the ways in which you're collaborating with the legal services partner, or for legal services partners, the way you're collaborating with healthcare partners. What are some of the work that you're doing that might fall into some of these categories, or is there additional or different work that you might that this might inspire you to think through of ways that you can build your collaboration? And go to the next slide. Our colleagues on our children's team here at Futures have built this framework as well that I have always found really helpful and sort of inspirational as well, that they talk about building protective factors, and that the studies show that protective factors can lessen the impact of domestic violence, both for children and adult survivors, and then also promote safety, healing, and well-being. So some of the domestic violence protective factors are related to individual and relational attributes, as well as environmental and social conditions. They help reduce the impact of domestic violence risk, build individual strengths, promote healthy development, and establish conditions that support the safety, healing, and well-being of survivors. There's a link in the slide to an issue brief all about these interrelated domestic violence protective factors. That would, just another resource for you all to consider looking at, that might also help with your work. Now, with that, I'll pass it on to Bethany.
Thanks, Elena. Thanks, Kim. Just want to pause for a moment and see if there are any questions from any of the Learning Collab participants before we move into the next phase, which is talking about medical legal partnership as an approach. Any questions from anyone so far? And you're welcome to also unmute. This is a learning collaborative, not a webinar. You don't necessarily need to use the chat, but as you can see, Elena was paying attention to the chat. We're all looking at it and we're reading out responses. I will go ahead and pose a first question before we dive into this part of today's learning collaborative session. I only saw one person in the attendee group that has MLP as a part of their description. And so can we just take a really quick poll using the chat? Do you have a medical legal partnership? Type yes or no right there in the chat. And as you all type yes or no, to the question, do you have a medical legal partnership? I'll proceed with the semi-didactic portion of my presentation, but I will be continuing to pause to pose questions. So it's great to see that several people actually do have medical legal partnerships. The question we're posing in this part is, how can the MLP approach address and prevent intimate partner violence and exploitation? So even if you don't have a medical legal partnership formed, what we're hoping to do is really level set a bit for those who don't have it, don't know what the MLP approach looks like, and give you some ideas for how you can approach development of a strategy, even starting out with finding the right partners throughout the community to begin reaching out to, finding out what they do, understanding what the legal services folks actually do on legal cases that you refer to them, and then what happens with all of the other social issues that still need to be addressed. So let's go to the next slide and first just do a quick just definition, just define what we talk about. For those of you in the MLP space, or if you've tuned into the National Center's trainings before, you know this pizza pie slice. It comes from our Health Center MLP toolkit that is linked in the slide deck, and we'll make sure we put it in the chat for folks to see. But one point I want to make really clear is that when medical legal partnership as an approach embeds lawyers as members or specialists of the healthcare teams to create all of those impacts you see, the healthier patients, the stronger health center workforce, improved health equity. It's not just because they are doing activities related to direct legal assistance, such as, for example, helping a client with an eviction case, or helping someone obtain child support, or helping someone file a protective order. They're also conducting the trainings that many of you are probably saying, I don't know what a legal need is. I don't know when I can refer to, or what type of question I should be asking the patient that amounts to a legal need. So MLPs do more than the legal assistance. They also provide those sorts of trainings to help you all in the healthcare team on the healthcare side of the equation, or for the DV advocacy program teams, help you understand and build knowledge and capacity to strengthen your workforce as a part of the response to social needs for survivors and victims of IPV and exploitation. They also engage in clinical level changes related to clinical practices. So you heard Kim explain the health center IPV protocol. Legal teams can help be a part of that I typed it and now I can't say it. Operationalizing the protocol to ensure that in the workflow, they also are part of the process for ensuring that once you've gathered the information as a result of that protocol, they can be a part of the referrals if that's what you're utilizing it for. And then finally, the policy level changes. MLPs continue to be one of those approaches that help to go from patient to policy level strategies, doing the hot spotting through the individual interventions to do the systemic sort of change that we see through legislative, regulatory, big P, little p policy work. So it's not just legal assistance. It's the point we really want to get at. It's not just the one-to-one cases that they're working on. They're really doing systemic changes. And that's the difference between just sending a referral to someone in the legal community and in your communities where you work, as opposed to applying a partnership, collaborative approach in this methodical way. All right, let's go to the next slide. Just speaking of systems level changes, right? This is what we typically utilize as a sort of visual to explain that, we're looking at social determinants of health, such as a food desert, and identifying social needs as a result of that social determinant of health, that food desert, right? You have a family in a food desert that needs fresh food. They don't have access. what can legal services do, or what legal needs arise because of those social needs that legal services providers can address. They can help that family apply for or file an appeal after SNAP benefits are incorrectly cut or outright denied. And there are patients and policy stories stemming from this exact example as well. Let's go to the next slide. On this next slide, many of you have seen the iHelp chart and know for different types of populations, and this is pretty easily transferable across the board. So I want to pause for a second and ask someone in our participant group to take a look at the iHelp chart. And for any one of the types of issues or needs that you see on the right-hand side of the screen that lawyers can help with, would you have an example? And you can go to the obvious choice, right? Personal family stability, of how a patient may come to you and then be assisted. Anyone want to volunteer? I'll pick one because I know we've got limited time, but I told you all I would be interactive. And I've got more interactive slides. So just looking for one person to unmute and share any anecdote to demonstrate how this plays out. I can pick an MLPer because now we know. Now we know who's got an MLP.
I think obviously the income and insurance situation.
Callie, you want to introduce yourself first? Let people know who you are. I can tell you're
Sure.
speaking.
My name is Callie Query. I am the managing attorney of Lawyers for Kids at Nationwide Children's Hospital, which is a traditional medical legal partnership, but we actually started and continue to serve our affiliated family violence center, which is called the Center for Family Safety and Healing. I actually started as the sole lawyer there, providing direct legal assistance to victims of family violence, kids and adults. So yeah, I mean, family law obviously is obvious, but but income and insurance, I mean, giving advice on food stamps eligibility, benefits eligibility to women who are contemplating leaving a situation can be really powerful, so that they can understand that you know, even if they lose their husband's insurance, for example, they're going to qualify for Medicaid because their income is so low, or things like that with regard to income and stabilization of the household income.
It's a great example, Kelly. Thanks so much for sharing. It's the perfect segue to what I'm going to plug in the chat, which is LSC reports on an economic report. Two economists conducted an academic study finding that increased access to civil legal aid was one of three major factors correlating with a 21% decline in the incidence of domestic violence from 1993 to 1998. And some of the services that led to that decline were those empowerment services. So helping the individual access those sort of public benefits like food stamps, like cash assistance, like ensuring stability of health insurance coverage once they leave the situation. We all know, some of us have too much familiarity with these sorts of situations where a victim or survivor may feel stuck. And it's not just about getting a protective order, it's also about, as Elena and Kim have noted today and in other presentations, that there is a lack of financial access or freedom. And so they are unable to get out of that situation on their own or figure out how to navigate or even know about their rights that can be protected to get out of those situations. So the studies have shown that civil legal aid is even more effective than access to shelters or counseling services in reducing domestic violence. To Kim's point that I now lost in the chat, but noting that legal needs can help, addressing legal needs can be both preventative as well as a treatment for survivors of IPV, exploitation, and human trafficking. All right, so let's go to the next slide. Thanks for sharing, Callie. On the next slide, I just want to note that, you know, for many of us, and I think I saw someone from a public health department as well, but we may not always know, you know, who those people are in the community at the different organizations that can help to address the various needs that we talk about when We talked about that trifecta, right, with medical legal partnership, the legal providers, the health centers, and the DV advocacy programs. So I want to see if we might have some time to unmute and hear from a couple of people. I always like to use the legal services provider bucket first and say, to those of you who are not legal services providers, do you have some examples of who you would reach out to when you're trying to fill that gap in terms of services, legal services in the community? Who would you reach out to? For the lawyers, again, in the participant group, don't answer this question because I know you know this list is longer than where you work. So anyone want to unmute from the healthcare or DV advocacy program bucket and share with us some examples of legal services providers? Or the types of organizations. I'm going to try to call someone out from the healthcare side. Thanks, Wanda. Wanda, if you're unable to unmute, I'll go ahead and read out what you typed in the chat. So the Family Justice Centers in New York City. Wanda, do you want to tell people what they are? For example, are they a civil legal services provider organization? Are they funded by the by LSC, the Legal Services Corporation, almost the federal agency twin to HRSA, but for legal services providers? Do you mind telling us a little bit more?
Hi, everyone. I should know this, but I'm not really sure. I think that they're a city-funded, service, but basically it's like a wraparound services for victims of IPV, and you could get legal services, counseling, access to sort of concrete needs, housing, social services, that kind of stuff. I'm pretty sure it's by some government entity in New York City. They are. Maybe my partner Cynthia knows.
I think actually that funded by the city, part of the mayor's office. That's awesome. They chimed in and helped you out. Cynthia helped you out. Who has another example? I think I'm glad, Wanda, that you volunteered that and provided that example, because that's the independent organization. Any other examples of legal services providers? Like, what if you aren't in New York City or a setting with those independent civil legal services organizations? Where else might you go? Take one more example. Anybody want to chime in? From the MLP bunch, now I'll let y'all chime in and talk about another example so I don't exhaust the time. Looking at Elena and Kim, my co-panelists, I want to be very respectful of our time. And Kim also typed in the chat, by the way, our health consortium at the county level has an MLP. So Kim, I might pick on you, but I'm looking at the other participants to see. Great. Camila is holding it down for everyone. So Camila typed in legal clinics with law students. Any of the MLP folks have a law students, an academic partner? Make sure I pay attention to chat. And then I'll continue to move us along.
It's not our traditional MLP, but our Family Violence Center does fund through a law school civil protection attorneys to represent victims of intimate partner violence.
Nice, thank you. Callie, was that you? I think because I don't have my Zoom set up right, of course.
Sorry.
Okay, all right. Thanks for sharing that. And then Kim, you want to speak that one out? Keep the tone of.
Yeah, I mean, I know you're talking about formal MLPs, but for us at Asian Health Services, our health center, well, we have the consortium, which has a formal MLP with Bay Area Legal Aid, but then our individual health center, when we're working with our Asian immigrant and refugee patients, we have actually an informal, like we're subcontracted through Asian Pacific Islander Legal Outreach. So they see a lot of immigrant and refugee issues and domestic violence and some exploitation, human trafficking, and then they subcontract out to us, and then we have like this referral, like bi-directional referrals, where we help out their clients, they help out our patients, and we've used it for a number of patient cases, and we wrote about that in that article.
Thank you. Yep, perfect. This is great. So the point of doing this little exercise is to get to, I think, what sometimes we hear at the National Center from healthcare providers who are just beginning to think about developing these partnerships and they're really not sure where to start. And so we really want folks to just start with understanding the landscape of potential partners. And there's no reason to default into thinking that, okay, I've seen this one model of medical legal partnership or an informal partnership, and it involves a fully baked in and integrated sort of model where they've hired the attorney. There are examples and models where, because of the nature of funding that certain populations have dedicated needs or wraparound services for, you might have legal services corporation funded legal aid provider organization in the community. And on the other hand, you may have none of that, and you might have an academic partner that has a law school, or if just depending on how we're talking about this and just focusing on the legal services provider bucket, but you might have a law school, right, that is already running clinics and they have supervising attorneys ready to go, and you're able to plug that staffing gap in your partnership model. And so similarly, legal services providers, I used you as the example, but do find out who the DV advocacy programs are, do find out who the health centers are in the community. They're on the maps. And I think Camilla, I think you might have a link that you might be able to share for us. If not, we'll share it towards the end so that you'll be able to find these programs in your community. And same thing for health centers. There is the Find a Health Center website that HRSA runs, and that's how you can find out how it overlays with where you are in your community. All right, so I'm going to go a little bit quicker through the next few slides here and talk a little bit about like, what do you do next? So if you've identified, the potential partners to form your partnership for addressing and preventing IPV and unmet needs for those who are experiencing human trafficking or exploitation. The next thing you may want to do is say, okay, what of those needs are we going to address? And take a step back from that and say, first of all, how are we even assessing the social needs? The protocol was mentioned, but how are you also integrating these screening tools in a way that they work together, that you're not duplicating collection and sharing of information, and you can actually run efficient programs? So the next step that you might want to do and take, and this is a part of the Health Center NLP toolkit, is review the data that you are gathering from the various screening tools that you're utilizing. For legal services providers, you have intake forms, and they probably are asking, to some degree, some of the very same questions that healthcare providers are asking in their social needs screening tools like Prepare or Aunt Bertha. And for DV advocacy programs, right, you're certainly asking the sorts of questions that others are picking up in these exact same sorts of intake and screening tools. But when working on a partnership, it is very, very important that you align these specific, for the partnership's sake, that you align these tools and figure out what you're all asking. And you may not have to change the way the question is asked. It's just deciding, okay, which ones align for what you're trying to address. To get this done, make sure you're speaking to the various staff that can be involved in the workflow. And I'll talk about workflow in just a moment, and include the clinicians. Absolutely include the clinicians. Remember, folks who are showing up at the health centers in particular, that's your gateway, right? People know when something hurts on their body. They may not know exactly what it is, but they're probably going to be showing up for healthcare way before they ever know that they have a legal problem. And they'll probably be too afraid to necessarily approach a DV advocacy program. So they're probably going to show up in the health center first, right? So talk to the clinicians about what those visits look like in the exam room. I recently heard from some medical residents at GW that even in a health center, they didn't know what to do next when they had that hour-long visit, and it was a medical visit, and they just didn't know where to go next. It was teaching them about MLP. So let me continue. Take stock of your existing priorities and capacity, examine your EHR data to help do some of that hot spotting and risk stratification. And then if necessary, then talk to your legal partners about what additional legal needs assessments may need to be done. as promised, on the next slide, we do have a workflow tool that folks can utilize. This is on the National Center's website, but it's also built into our Health Center MLP toolkit. I encourage you all to, and I promise that we'll plug a link to this, to the toolkit, so you can get this, download it, tear it apart, right, as you're working on strategies, and figure out who actually you will plug in to the different elements or the aspects of the screening and workflow tool. So for the screening section, right, you see that someone's designing screening questions. Who is that and why? Is it that you're starting with your DV advocacy providers to say, am I like the one who's asking the right questions? Their voices are absolutely critically and important and essential to this process. Talk to them about what the implementation of the screening process looks like. And then obviously you're going to bring in your legal services providers to help you continue that workflow to understand, what does the referral look like once the screening is done? Where are you capturing that information if it started with the health center? And then how is it flowing out to the legal services providers? The legal services providers can absolutely answer the question for you about consents, because I'm sure on the healthcare side, if you don't have an MLP, your question is, but what about like client confidentiality and patient confidentiality, right? Don't lawyers have their own requirements, right? Yes, of course. But the benefit and the value of partnership is that your legal services providers have MOUs that can be developed, as well as consents for the patients to sign off to be able to continue that referral. And finally, as you see, the follow-up and continuous quality improvement. So you're closing the loop on those referrals and getting to some of the health impacts, like what Elena showed on that slide with the chart showing the biometric data related to some of these incidences of IPV or human trafficking. So I think that's it with my slides. Catherine, I want to thank Catherine on our National Center team for plugging links to both the workflow, which is a call out from the toolkit itself, but the full toolkit is also linked there. And from that, I will turn it over to Kim.
Great, thank you. That, you know, Bethany, listening to you, I love listening to you because I always hear and learn more insights and nuances for the work that you do and the work and how it can apply to the work that I do in the health center. And so I'm going to switch gears a little bit. We're going to talk a little bit about the Futures Without Violence and Health Partners on Intimate Partner Violence and Exploitation approach to intimate partner violence and exploitation. It's a universal education approach. And you heard Bethany talking about their screenings and referrals in the legal side. And in healthcare, we often do screenings and referrals. I mean, that's kind of what we do. We do screenings, you know, for cervical cancer or colon cancer or high blood pressure or diabetes. And in the past, we also used to think about intimate partner violence and doing screenings that way. We have since shifted and become broader in our thinking, because when you think about screenings entails you trying to elicit a yes or no answer from the patient or the client. Yes, you've been hit, pushed, shoved, kicked, hurt in some way in your relationship, or no, you haven't, right? But we know through all of the great work that Futures has done that there are many barriers to a patient disclosing whether they have been in a relationship that has had violence in it, or exploitation or trafficking, right? And so when there are barriers to disclosure on the patient side, whether it's shame, stigma, what have you, or on the provider side, I don't feel comfortable asking these questions. I don't know what to do. We don't have any referral resources, or I don't speak the same language, or whatever it is, there's barriers. We have since shifted to a universal education approach. And this is really key and important, because universal education gives us the opportunity to reach out to patients who have never experienced intimate partner violence and human trafficking. We give them education about it, and that's preventative. 2, to those who are currently experiencing it, IPV and human trafficking or exploitation, and give us a way for early intervention, right? And 3, for those who may have had a lifetime history of it in the past, maybe not currently, but may still have some post-traumatic stress from it, or chronic illnesses or injuries or pains or relationship difficulties or emotional pain from the past history. So it gives us a way to reach out to everybody, provide education, and to provide those referrals and resources. It's really, really important. And I think, you know, this is something that we can parallel in medical legal services or in the domestic violence advocacy side as well. So universal education, very important. Next slide, please. So these are some of the barriers I spoke about that someone might not choose to disclose, and there's very many barriers, and you can see here lack of U.S. laws and contractual obligations in cases of labor trafficking, or the lack of awareness of victim status and rights, not knowing what's going to happen with the information, fear of systems or police involvement. All of these intersect with, you know, the medical legal side or the legal services side. And so, you know, this is really an issue for all of us here at the table today. Next slide, please. So the universal education approach that Futures Without Violence does is basically a brochure-based intervention or information-based intervention known as CUES, which stands for confidentiality, really establishing that confidentiality and rapport with patients, universal education, talking about healthy relationships, talking about exploitation, talking about trauma, abuse, and violence in a way that provides education to patients so that they can know what is healthy or in terms of exploitation, what are some of their rights in labor, and then empowerment, where we are giving 2 of these cards, and basically the script is, I have, you know, 2 of these cards. It has information about these issues. You can use it for yourself or a friend, because people have altruism and they're much more willing or able to help somebody else first before they can sometimes help themselves. So that's the empowerment. We have this information for you or a friend or somebody in your community or someone in your family, because we know these issues are prevalent in society. And then support. These brochure cards have a lot of information on where to get resources. Next slide, please. So this is an example, an overview of the CUES intervention. Normally, you know, confidentiality, disclosing the limits, when we have to break it, if they're at risk of imminent harm for themselves or harming themselves, suicide or homicide, for example. Universal education and empowerment, normalizing the activity, giving 2 cards, and making the connection between healthy and safe relationships and how it impacts their health, their physical function, you know, their body symptoms, their chronic disease, their mental health. You saw that initial slide, the slide up in the front that Elena had talked about on why partnerships matter. It matters because there are health impacts. There are health impacts, and we want to prevent morbidity and mortality for our patients. That's what we do in medicine, in doctoring. And then the support, the hotlines and the information and the local resources. Next slide, please. So this is something for the legal services providers. I think the DV program advocates already know this, but this, and this is for the health center folks. This is what survivors say they want us to do when they disclose. They want us to listen, be judgmental and open, give them support and resources, and not necessarily push for the details or the disclosures, you know, or all of the context of what they're going through. Okay, so this is what they say they want us to do. Next slide, please. And these are some scripts that you can use on the legal side and the medical services side and the DV program side. So I'm glad you told me about this. Sorry, I'm so sorry this is happening. No one deserves this to happen to them. You're not alone. Help is available. I'm really concerned about your safety. So recognizing the situation, validating their experiences is really key to building that rapport and that therapeutic alliance with your clients or your patients. Next slide, please. And then providing that warm referral. And this is where partnerships really matter. Because I can pick up the phone in my exam room and say to my patient, hey, I have Bethany from the GW Medical Legal Partnership. She helps us with our patients who, you know, they might need a restraining order, or, you know, they need some help with finding some housing, or even the domestic violence program. I have on the line, I have Elena from the Futures Without Violence Domestic Violence Advocacy Program, and I can call them directly, or their coworkers. And you want me to do that for you? And we can make that connection right here in the exam room. And so this is really, really helpful to have that relationship building and this warm referral on the back end, so that when I make these initial calls, or your providers in their who are on the front lines doing the groundwork are interacting with clients and patients, that they can make those direct referrals right then when the patient is willing to accept them. Next slide, please. I think this is you, Elena.
Yeah, so just like Kim mentioned, Futures has developed a number of different safety card tools that can be used with the universal education approach. They come in different languages. They many of them are community or population specific. They're available on our Health Resources Center store. And the link is there in the slide. Feel free to go on and order them if you find that they might be useful in your work.
By store, you mean they're free, right?
Yeah. Yeah.
Not like a store. So.
Oh, yeah, no. And then just to follow up on something that we mentioned earlier, we have a toolkit online at ipvhealthpartners.org that was developed by and for community health centers in partnerships with the domestic violence programs. It has guidance and information on patient privacy, disclosing the limits of confidentiality, more scripts like the ones that Kim shared earlier, information about tech privacy tips, telehealth, COVID. So encourage you all to check it out. And cues, more information on cues as well. Encourage you to check it out.
And sorry, I'll unmute. Anyone can share this. We'll have in the slide deck when it comes around, there will be a link to, but there's also a link to this in the welcome packet, the Health Center MLP Toolkit. Catherine from the National Center team also plugged a link to it in the chat. And we'd encourage folks to download anything you need and you find particularly helpful on the resources page of the National Center's website. The 9 conversations are just the guide, if you will, to having the conversations with the various potential partners in building your health center-based MLP. So with that, I think we are at the end. Elena, can I take it back to you to let our participants
sure.
know?
Yeah, so this was the first of our 4 learning activities, like I mentioned before. At our next session, session 2, we'll be talking about developing these partnerships with health centers and legal services programs. We'll be hearing from Pat Medage, who is a civil legal services attorney at Colorado Legal Services, specializes in cases related to human trafficking. And we'll also have a lot more time to hear from you all about challenges, questions that you have, the resources that would be useful to you all to think through some of those challenges so that we can, be learning all together. There's also a link in the chat to the evaluation, and we really appreciate your feedback. Really helpful for us as we develop these learning collaboratives, so please take a minute to fill it out. And with that, I'll let you all go, and just to say hope to see you on May 12th. And thanks for joining us.
Thanks, everyone.